Hello, and thank you for listening to my presentation today. My name is Hannah Backman, and I am so excited to present my DNP scholarly project. It is titled Implementing Brief Nutrition Education to Enhance Recovery in Patients Undergoing Outpatient Detox. My project focused on whether a brief, structured nutrition education intervention could improve early recovery outcomes in individuals with substance use disorder who are undergoing outpatient detoxification. I want to begin by thanking the people who made this project possible. First, I'd like to express my sincere appreciation to my committee chair, Dr. Foy, for her steadfast guidance, encouragement, and thoughtful feedback throughout the project. I also want to recognize my second readers, Dr. Snell, Dr. Sturrer, Dr. Buck, and Dr. Stegman, each of whom offered valuable insights that helped refine the focus, improve the rigor, and elevate the impact of this work. Additionally, I am incredibly grateful to Dr. Canfield, my community member, for providing real world perspective and unwavering support during the implementation phase at the clinic. This project has truly been a collaborative effort, and I feel so deeply honored to have had the support and encouragement of such a knowledgeable and dedicated committee. The aim of my project, like I mentioned briefly earlier, was to evaluate whether implementing brief, structured nutrition education during the outpatient detox process could improve early recovery outcomes, specifically relapse rates, detox program completion, and follow up attendance. The problem I identified was that nutrition, despite its critical role in physical and mental health, is rarely addressed in outpatient substance use treatment programs. Research shows that individuals with substance use disorder often suffer from malnutrition and poor dietary habits, which can worsen mood, reduce energy, increase cravings, and ultimately raise the risk of relapse. Despite this, most outpatient detox programs, including the clinic where this project was implemented, do not include structured nutrition education as part of routine care. This represents a major gap in treatment that may be contributing to poor outcomes, especially during the vulnerable early recovery period. Recognizing that nurses already conduct brief assessments during detox intake at the clinic where this project was implemented, I saw an opportunity to integrate brief, evidence based nutrition education into that existing workflow. The idea was to empower nurses to deliver meaningful, relevant education at a critical recovery juncture without requiring new staff or costly resources. In short, this project was designed to close a care gap and improve outcomes using a practical, sustainable, and holistic approach. The literature highlights several key findings that shaped my project. First, individuals with substance use disorder often suffer from significant nutritional deficiencies, including low levels of vitamins A, D, E, iron, and magnesium, which all negatively impact both physical and mental health outcomes. Poor nutrition has been directly linked to increased relapse risk due to its effect on mood regulation, energy, and cravings, factors that are especially critical during early recovery. Studies also show that individuals with substance use disorder commonly consume high sugar, low nutrient foods during early recovery, which can contribute to weight gain and increased metabolic complications. However, there's promising evidence that nurse led nutrition education can improve patients' knowledge and quality of life, even if body mass index doesn't change significantly. MyPlate and SnapEd have emerged as practical, evidence-based tools to support education in this area and can be adapted for individuals in substance use recovery. One important gap in the literature is that most studies take place in inpatient or residential treatment settings. Very few have examined brief interventions in outpatient detox environments like the one used in this project. Finally, there's limited research directly connecting nutrition education to reduce relapse rates or increased follow-up engagement in real-world outpatient programs, and no standardized protocol exists for this population. My project was designed to address that gap. My project was guided by Lewin's change theory, a well-established model that describes change in three distinct phases: unfreezing, changing, and refreezing. It provided a structured and practical framework for introducing and sustaining a new clinical intervention in the outpatient detox setting. In the unfreezing stage, I identified that nutrition education was a missing element in the clinic's standard care. Conversations with staff and leadership confirmed that this was a shared concern. This stage was all about building awareness, creating buy-in, and addressing potential barriers like time constraints or limited nutrition knowledge among nurses. During the changing phase, we introduced the intervention. Nurses were trained to deliver brief one-on-one nutrition education based on the USDA MyPlate guidelines. The education was built into the detox intake process, and EMR templates were modified to support documentation. Finally, in the refreezing stage, the intervention was embedded into the clinic's routine workflow. Staff feedback was positive, and the process became part of standard nursing care. Leadership support ensured that the change was maintained beyond the project period. Lewin's theory was instrumental in guiding the formation of this work. It helped me plan methodically, anticipate resistance, and ensure long-term adoption. By following these stages, the project moved from idea to sustainable practice change, reinforcing the value of applying theory to real-world clinical improvement. This project used a quality improvement design, specifically a retrospective chart review comparing outcomes before and after implementation of a nutrition education intervention. The setting was an outpatient detox clinic in the Western United States where I had direct access to the patient population and clinic processes through employment. The intervention involved brief, structured nutrition education provided by nurses at the time of detox intake using USDA's MyPlate guidelines as a practical and evidence-based foundation. We embedded the intervention into the existing workflow to ensure feasibility and sustainability. The Plan, Do, Study Act, or the PDSA cycle, guided the process. In the planning phase, we collaborated with clinic leadership, trained staff, and integrated documentation of the EMR. During implementation, I observed and adjusted workflows. Finally, we studied the outcomes and made recommendations for future practice. This design was selected because it allowed me to compare meaningful patient outcomes, relapse rates, follow-up attendance, and detox program completion across 2 timeframes. The retrospective chart review method enabled efficient data collection from existing records with no disruption to patient care. It was well suited for answering my PCOT question, which was whether a brief nurse-led nutrition intervention could improve early recovery outcomes in individuals undergoing outpatient detox. So as I mentioned earlier, to evaluate the impact of the nutrition education intervention, I conducted a retrospective chart review using a total sample of 132 patients. These individuals were divided into 2 groups, 77 in the pre-intervention group who received standard care between November 2023 and February 2024, and 55 patients in the post-intervention group who received the brief nutrition education between November 2024 and February 2025. The age of participants ranged from 18 to 67 years, with a mean age of approximately 35 years across both groups. This aligns with the typical age distribution seen in outpatient detox programs, where young and middle-aged adults are most often represented. In terms of gender, the pre-intervention group consisted of about 53% male and 47% female, while the post-intervention group had a similar distribution, 56% male and 44% female. This balance supports comparability between groups and helps reduce confounding. The racial and ethnic makeup of the sample was approximately 98% Caucasian, which reflects the demographics of the region where the clinic is located. While this limits the generalizability of the findings to more diverse populations, it provides an accurate snapshot of the clinic's patient base. All participants had a documented diagnosis of substance use disorder, primarily opioids, alcohol, or stimulants, and were actively enrolled in the outpatient detox program during the respective timeframes. Inclusion criteria required that patients be within the eligible age range, have a qualifying substance use disorder diagnosis, and have documented data for relapse, follow-up, and detox completion. Exclusion criteria included individuals outside the time window, as well as those that had incomplete or missing documentation. By applying consistent inclusion and exclusion criteria and reviewing consecutive records, I aim to minimize bias and improve the reliability of the outcome comparisons between the two groups. To evaluate the effectiveness of the nutrition education intervention, we use two main statistical tests. I am very grateful to Dr. Pauls, our university statistician, for his help in this matter. So the two main statistical tests that were used were the z-test for the difference of two proportions and the chi-square test. The z-test was selected because our primary outcomes, relapse, follow-up, attendance, and detox completion, were all binary variables. Each patient either relapsed or didn't, completed detox or didn't, and attended follow-up or didn't. The z-test allowed me to compare the proportions of patients in each group who achieved these outcomes and determine whether any observed differences were statistically significant. For example, the most important finding was that relapse rates dropped from 76.6% to 60%, and the z-test confirmed this difference was statistically significant with a p-value of 0.0202. I also used a chi-square test to evaluate whether demographic variables like gender and diagnosis distribution were similar across groups. This helped ensure that any differences in outcomes weren't due to major differences in sample characteristics between the pre- and post-intervention groups. Both of these statistical methods are ideal for a retrospective chart review with independent pre- and post-intervention groups and categorical outcomes. They allowed me to assess the effectiveness of the intervention using real-world clinical data while keeping the analysis clear and focused on practical significance. My project revealed a statistically significant improvement in one of the three outcome measures. As I mentioned earlier, the most notable finding was that reduction in relapse rates. In the pre-intervention group, 76.6% of patients relapsed within 1 month of detox. In the post-intervention group, after nurses delivered structured nutrition education, this number dropped to 60%. The z-test for this comparison yielded a p-value of 0.0202, like I mentioned before, confirming statistical significance. However, follow-up attendance decreased slightly from 67.5% to 61.8%. This difference was not statistically significant, with a p-value of 0.2485. While this was in the direction we hoped for, it's possible that external factors like appointment availability or patient transportation played a role in follow-up behavior. Lastly, detox program completion remained stable, 35.1% in the pre-intervention group compared to 34.5% post-intervention, with no meaningful statistical difference. Overall, the intervention demonstrated a clear benefit in reducing relapse with minimal disruption to workflow, no added cost, and strong feasibility for outpatient settings. Like any quality improvement project, this one had several limitations that may have impacted the results. First, the sample size was modest, especially in the post intervention group, which included just 55 patients. While the relapse rate reduction was statistically significant, a larger sample could increase the strength and generalizability of the findings. Second, this was a single site study conducted at one outpatient detox clinic in a predominantly Caucasian population. As a result, the findings may not translate to more diverse communities or inpatient treatment settings. Another limitation was the retrospective chart review design, which means we relied entirely on existing documentation. If follow-up visits or relapses weren't recorded correctly in the EMR, that could have led to misclassification of outcomes. Also, the follow-up window was fairly short, just 1 to 2 months after detox. While this captures early relapse, it doesn't provide insight into longer-term outcomes like sustained sobriety or lifestyle changes. There were also several external factors that we could not control, such as transportation barriers, housing instability, or mental health comorbidities that may have influenced follow-up attendance or relapse. Lastly, the project did not include any qualitative data from patients or staff. Getting their perspectives on the nutrition education, whether they found it helpful, engaging, or relevant, could have added depth to the results and guided future improvements. Despite these limitations, the project still showed a meaningful and measurable impact, particularly in reducing relapse. But future iterations should aim to expand the sample size, extend follow-up periods, and include mixed methods for a more comprehensive evaluation. The results of this project demonstrate a meaningful impact, especially in reducing early relapse rates among patients undergoing outpatient detox. The statistically significant drop clearly supports the effectiveness of brief, structured nutrition education. This outcome is particularly important given that relapse within the first month of detox is common and often leads to readmission or treatment disengagement. The fact that such a modest, low-cost intervention yielded measurable results speaks volumes about the untapped potential of incorporating basic lifestyle education into addiction treatment. It reinforces the idea that recovery isn't only about medications or therapy, it also includes attention to physical health, nutrition, and self-care habits that influence mood, energy, and decision making. Although the changes in detox completion and follow-up attendance were not statistically significant, the intervention remained valuable. These unchanged outcomes suggest that other social determinants of health, such as transportation, housing, or employment status, may have played a stronger role in determining whether patients returned for care. This project also highlighted the value of nurse-led interventions. Nurses were able to implement the education with minimal disruption to workflow, and it was well received by staff. The project emphasized that change doesn't always require big investments. Sometimes the most effective interventions are those that build on existing resources and workflows. In terms of broader impact, the results support the integration of holistic, patient-centered approaches in outpatient addiction care and align with public health priorities to reduce relapse, improve engagement, and promote recovery-focused care models. This project has several significant implications for nursing practice, for patient care, and for the larger healthcare community. First and foremost, it shows that nurses are uniquely positioned to drive change in outpatient addiction care. By incorporating brief nutrition education into standard detox intake visits, nurses expanded their role from assessment and medication administration to prevention and long-term support. For patients, the intervention provided a rare opportunity to talk about nutrition, a topic that's often ignored during recovery despite its strong connection to energy, cravings, and relapse risk. The education was brief, relevant, and framed in a way that empowered patients to take action. Many patients aren't ready to dive into therapy or group work during detox, but something as concrete and practical as eating better can be helpful and can be an approachable place to start. On a systems level, this project demonstrated that effective interventions don't need to be expensive or time intensive. The entire education process took about 5 to 10 minutes per patient and was delivered using free evidence based resources like USDA's My Plate. There was no need for a registered dietitian or additional staffing, which makes the intervention scalable to other outpatient clinics, even those operating with limited budgets or resources. This work also supports the growing emphasis on holistic integrated care models in addiction medicine. Treating the whole person, body and mind, is essential for long-term recovery. Finally, the project aligns with key DNP competencies, leading quality improvement, translating evidence into practice, and influencing systems levels change. I plan to advocate for nutrition education in my future practice and encourage other clinics to adopt this model as part of comprehensive recovery care. In conclusion, this quality improvement project achieved its primary goal, implementing a nurse-led nutrition education intervention that led to a statistically significant reduction in early relapse rates among individuals in outpatient detox. While other outcomes like detox completion and follow-up attendance remained unchanged, the clear impact on relapse suggests that this intervention fills an important gap in early recovery support. The success of the intervention highlights the importance of including nutrition in addiction treatment plans. It also affirms that small, low-cost interventions, when grounded in evidence and integrated thoughtfully into existing workflows, can lead to measurable improvements in patient outcomes. From a nursing perspective, this project reinforced the critical role we play in patient education, health promotion, and holistic care. If I were to do this project again, I would add a longer follow-up window, perhaps 3 or 6 months, to evaluate sustained outcomes over time. I would also incorporate a qualitative component to capture patients' feedback and experiences with the nutrition education. Understanding what resonated with them and what didn't could help refine the intervention and enhance its impact. Looking forward, I plan to expand this intervention to other clinics, collaborate with colleagues to improve standard care protocols, and possibly publish the findings to contribute to the growing body of literature supporting nutrition and addiction recovery. Personally, this project and the DNP program as a whole have transformed how I view my role as a nurse practitioner. I've gained confidence in leading quality improvement, applying theory to practice, and navigating systems level change. Most importantly, I've learned that it's possible to lead with both evidence and compassion, and that thoughtful, patient centered interventions really can move the needle on recovery outcomes. I am deeply grateful for the experience and the opportunity to use my education to make a meaningful difference in the lives of patients and the future of nursing care. Thank you again so much for taking the time to listen to my presentation today. I sincerely welcome your feedback, thoughts, and encouragement as I continue to grow in my practice and contribute to improving care for individuals in recovery. Here is a list of references used for this presentation. Thank you.